Hi, my name is Heather Johnson, and I'm going to talk to you today about Project 80% Colorectal Cancer Screening Program and the roles clinical staff play in navigating patients from deciding to complete a colorectal cancer screening to the completion of the screening process. Listed here on the screen are my team and I, and I'm the program director in the Office of Health Policy and happy to share today our wonderful program that's statewide throughout Southeast Texas. Just an overview. Importance of colorectal cancer screening. We'll discuss the importance of screening and the different screening types. We'll review clinical roles in CRC screening, workflow and responsibilities of those roles, and how the pivotal role they play in making sure adherence to screening increases in FQHCs and community settings, and also best practices for coordinating a community screening program. And I'll give some highlights, implementation highlights from our Project 80% Colorectal Screening Cancer Program here at MD Anderson. Overview of colorectal cancer. Colon cancer is a disease in the colon or large intestines. So when I reference colorectal cancer, I'll be talking about a disease that starts in the colon, or rectal cancer, which starts in the rectum. So CRC, I'll also use that synonymously with colorectal cancer, is a disease that starts in either location. So why is it important that we're talking about this today? It's the third most common form of cancer in the US. And often there are no symptoms in the early stage. So screening and early detection is very important for this type of cancer, as it significantly improves outcomes. Burden of cancer, colorectal cancer in Texas. When you combine colon and rectum cancer expected new cases in 2025, as you see here, it's almost over 13,000 people were expected to be diagnosed with colorectal cancer in 2025, and over 4,000 expected colorectal cancer deaths. CRC screening methods. Colonoscopy remains the gold standard for colorectal cancer screening, and I'll talk more about that in later slides. But I just wanted to review with you all today the different types of screenings, so patients and participants in screening have an informed decision and are aware of their options. So colonoscopy frequency, as you can see, has the longest frequency interval of every 10 years. It's diagnostic and therapeutic. That's a pro. A con of it is oftentimes you hear about the prep. You have to have moderate sedation most times with colonoscopy screenings, and it's the most invasive of the testing options. The FIT test, which is administered annually, it's non-invasive, and the lowest cost maybe of all of the screening options. However, it's a lower sensitivity. This test tests for blood in the stool after a fecal sample is sent to a lab. Stool DNA. Also, it's administered, can be between 1 to 3 years, although it has a higher sensitivity than FIT, but the cost is a little bit more, and the likelihood of false positives increases with this type of test. CT colonography, or what we call sometimes a visual colonoscopy, the interval is every 5 years, a little less invasive than a colonoscopy, but you do run the risk of being exposed to radiation. And if you were to have a positive finding from this test, you would have to get a colonoscopy. A flexible sigmoidoscopy every 5 years, the same as the CT colonography, is minimally invasive, but it can be combined with a FIT screening. It's limited reach in that it only scopes a certain segment of the intestines, And also, if you were to have a positive finding or abnormal finding from this test, you still would need a follow-up colonoscopy. And more recently introduced to CRC screening or blood tests, minimally invasive and convenient. They're recently FDA approved, but not yet supported by the U.S. Preventive Service Task Force, as they don't consider enough evidence for widespread community screening. Colorectal cancer average risk participants. So I wanted to talk to you all today about the screening pathways. We talked about I outlined the different types of screening, but I just wanted to highlight why colonoscopy is the gold standard for screening, because if you were to have an abnormal or positive finding from any of the other screenings, you would still be referred for a colonoscopy in the end. So for those patients who get a colonoscopy up front, they wouldn't have to be referred for further testing, as the precancerous lesions or polyps can be removed at that time, and then they would have recommended screening intervals following that colonoscopy. I wanted to also share increased risk participants. These are participants that have a personal or family history of colon or rectal polyps or colorectal cancer. They are also, they bypass those other screening options and are recommended to go straight to colonoscopy due to that increased risk. And they're also eligible to be screened at shorter intervals and earlier. Flow charts. Just wanted to show you an example of a community screening flow charts and how it takes a village to be able to screen participants and to get them from point A all the way through the screening process. And so we work with Project 80%. We work with community clinics, FQHCs and community clinics. We work with community labs, patient navigators through our project. The patient has a big responsibility throughout the process, and also our billing and endoscopy partners all play a role in getting the patient successfully through the screening process. I wanted to highlight on this chart all the education touch points that may be necessary to have with a patient to make sure that they successfully make informed decisions and to increase the likelihood that they complete the entire process. That's from screening patients for their family history or personal history of polyps, and whether they decide to have a fit or they're eligible to go straight to colonoscopy due to an increased risk, and also to their pre and post-op appointments, as well as the procedure and navigation to treatment if necessary. And so it's a lot of touch points and a lot of educational opportunities that are necessary to have with the patient from all of our partners to make sure that the populations or the patients are successfully complete the process. Again, communication matters in CRC screening and navigation, and it has to be done consistently, as you see from our previous slide. Communication helps build trust and reduces that anxiety. You have to be clear and compassionate with these patients just to make sure that they understand the screening process. It helps reduce the fear up front of misconceptions about colonoscopies or colorectal cancer screenings in general, and it increases the likelihood that the patients will follow through with their appointments and procedures. It also improves understanding and health literacy. Many patients are unfamiliar with colorectal cancer screenings and may have a low health literacy. So explaining with purpose, explaining in steps, and preparing for those questions and help following up in plain language ensures that they know what to expect and why it matters each step of the way. Consistent communication enhances adherence to screenings. Patients are more likely to complete screenings when they feel supported. So regular communication, whether it may be through calls, texts, or in-person visits, keeps them engaged throughout multi-step screening processes and reminds them of upcoming tasks that they may be responsible for. Addressing barriers early. Effective communication allows navigators to identify and help solve problems before they could potentially become a barrier that would stop the patient from completing the screening or drop off in the process. Promotes shared decision making by clearly discussing options and respecting the patient's preference. Navigators can empower the patients by helping them make decisions that align with their value and their health goals. And lastly, ensuring continuity of care. Ongoing communication ensures that patients are guided from initial contact through follow-up and increases the likelihood of early detection and timely treatment if necessary. The role of providers. MDs and nurse practitioners play a critical role in the screening process. The main thing that we rely on providers to do is to introduce screening at the appropriate time, which is now age 45, which is supported by the organizations that support that we follow are the U.S. Preventive Services Task Force, the U.S. Multi-Society Task Force, and American Cancer Society. So we use guidelines from all three of these organizations to help guide our screening program, Project 80%, and we help educate providers and clinic staff to start screening at age 45. Why age 45? While CRC incidence is rising in adults under 50, specifically in most cases, ages 40 to 49, most cases still occur after the age of 50. So, screening at age 45 for average risk participants is recommended at this time. The roles of nurses and medical assistants is very important throughout the CRC screening process. We discussed the different types of tests, the stool-based test, the visual test, blood test, colonoscopy as the gold standard. But these tests and discussing these tests and the different options in more detail after being introduced by the provider is very, very important and a critical point to ensuring that the patient follows through throughout the whole screening process. So we really rely on those medical assistants to carry home those educational points, provide additional pamphlets and information for the patients regarding screening that they discuss with their doctors, and also offering support as scheduling those appointments that most times are with outside specialties to actually complete the tests. The role of patient navigators. They help throughout the process greatly in building trust and awareness. With outreach and reminder calls, they help close those care gaps, help remove barriers for patients, and also help schedule the actual testing for the patient to ensure follow-up after the patient may have abnormal results from FIT or abnormal results from a colonoscopy. So trust grows when the message comes from familiar faces. So those community health workers and trusted leaders play a huge role in normalizing colorectal cancer screening and also providing culturally appropriate education and bilingual communication for those patients as they sometimes have to exit their trusted medical home and be referred to outside specialties where they may not be familiar. The role of GI specialists and endoscopy teams. They actually schedule and perform those diagnostic and screening colonoscopies. Sometimes it entails pre-procedure and post-op guidance. bowel prep before the procedure, and also documentation and pathology follow-up is sometimes necessary. So these specialists play a huge role in completing the screening for colorectal cancer screening. Patients that decide to have colonoscopy for colorectal cancer screening, and also communicating that information back to the provider that initially referred the patient, or the primary care provider, or the patient's home. And so they close the loop in that communication with the help of navigators, and making sure that the patient successfully completes the process. Quality measures and reporting. Reporting numbers, sharing data with providers, specialties, and sometimes patients is important on completion rate, adequate prep rate, and timeliness to follow up. We share this information through Project 80% throughout our entire network to help improve quality measures throughout the process. And so the sharing of information and reporting on which patients actually received maybe a fit kit, actually were scheduled and completing their appointment, helps the patient navigators, helps the patients, helps the primary care providers and the GIs assess how well we're doing at any interval of the process, and helps us to pinpoint the areas where we may need to improve. The CRC screening challenges. With every screening process, there are challenges. So data collection and reporting to help improve those quality measures is sometimes a challenge, and getting that information from all parties, and providing information sharing, streamlining that referral process, making sure the patient seamlessly gets from one step in the process to the next can sometimes be a challenge and be the result of patient drop-offs. We talked about communication throughout this process is very important, especially for follow-up of patients, to make sure that if necessary, an abnormal finding is navigated to the necessary specialty or treatment if necessary. And also it's program implementation and sustainability. Implementing a design program in different healthcare settings is sometimes a challenge, and making sure patients navigate those different systems is sometimes a challenge. Coordination with specialists, especially. Sustainability through collaboration. Most programs could not work or would not work without collaboration. So I want to highlight some of our partners, which is CPRIT, the Cancer Prevention Research Institute of Texas, that helps our program and helps sponsor our program in 3-year cycles to help us to implement this program in the communities we serve. The legend to the right just shows the community clinic sites that we service, as well as the endoscopy partners throughout our service network, and it's all made possible by funding and support through CPRIT, and more recently here, the Colon Cancer Coalition. To keep momentum, we prioritize sustainability, so shared funding, joint planning, and recognition with value partners help us stay engaged in the program for long term. Why community relationship matters. Community relationships help build trust and credibility. Community relationships are the heart of successful screening programs. Trust is built locally, so through familiar voices like regional CHWs, local organizations with shared goals, it makes screening accessible and acceptable for patients. Trusted community partners are most times advocated first-line educators for colorectal cancer screening programs, and they can help dispel myths and stigmas about colon cancer screening and help to improve motivation for those persons interested in screening. Community networks make it easier to connect people to screening services. It helps reduce those barriers like cost, transportation, and fear of leaving their community for screening and resources. And lastly, they help create synergy by pooling resources and fundings. We can reach more people with a broader impact with a stronger network of care in a patient's community. So we love to partner locally with community networks and help keep the services and colorectal cancer screening networks within a patient's community and near their medical home. Key takeaways from this project. Begin screening at age 45. We like to educate on the parameters, age parameters of screening to begin at age 45 and continue through age 75 routinely. As expressed, colonoscopy remains the gold standard, but there are other testings available like FIT that are strongly endorsed when colonoscopy is declined or unavailable for patients. So explore those multiple screening options with patients and tailor your approach to the individual patients. Remember, shared decision making improves a patient's adherence to screening. As expressed throughout the presentation, consistent communication throughout navigation process matters. Establish communication touch points to make sure that the patient is supported throughout the entire process. And lastly, timely follow-up of abnormal results is very critical. And that's the end of the presentation. I appreciate you joining me today, and I hope you were able to gain some knowledge from, in general, of colorectal cancer screening and the different roles that the different clinical roles, the difference that clinical roles play in ensuring a patient adheres to screening, how complex the screening process is for colorectal cancer screening. And if you have any questions, you can feel free to reach out to me through the Project 80% organization, especially to partner with one of our clinic partners if you have a patient or you know someone in need of a pre-screening. So thank you for your time.